it's all about?
Well, that's just basically what it is. You're laying there, you're relaxing, you're comfortable, and then they're just scanning over your body, you know, limb by limb and up and down.
It's actually sort of, it helps decrease your pain, and it helps with your breathing too, without medication. Lots of our nurses, I'd say 4 out of 7 of our nurses are Reiki certified. R-E-I-K-I.
Google it. Okay. Physician responsibilities. You're on.
I'm sorry.
The physician helps
Oh,
with
physician, you know, the nurse cannot come out to your house and make any changes without the physician. So the physician is always part of your plan of care. So don't be afraid, you know, you can sign up for hospice, the nurse is going to come out and make all these changes. No, she needs to call the physician and let him know something's not working right, something can be tweaked. The patient complaints are what we go off of, the symptoms of what the nurse goes off of. But the physician is always contacted.
Okay? So, what do we do? What symptoms do we take care of? Here they are.
Another thing we do that I had a patient that was amazed. Her mother had Alzheimer's and she fell out of bed and thought that her wrist was broken and she wanted to take her to the hospital to get it looked at. Well, we sent an x-ray to her house. She did not have to take her mother to the hospital. Had the x-ray done right there in the house. We determined the arm was not broken and we just wrapped it and did comfort care. The physician looked at the x-ray, not the nurse. So there is a physician looking at it. A radiologist looks at it as well as our physician, and we determined they didn't want to do anything except wrap it and comfort it.
Okay, but what if we had that patient that broke her hip?
Oh, I had a lady who also had Alzheimer's, and she was a bilateral above the knee amputation, and she forgot.
I didn't even notice it.
Yeah, she forgot she was a bilateral amputee, and she jumped out of bed and broke her head.
She forgot she didn't.
It wasn't funny. It's funny now. So I went out there again with the x-ray, and it was broken. It was a broken hip, but the physician, her primary care physician, determined that it was such a small fracture that surgery would not be in her best benefit. She was too debilitated to do the surgery. So we actually healed her within the next 6 months, and she came off of our services.
She laid in the bed before
We had
we
her
came, and she was laid in the bed after she healed. But what I like about this story, you know, as a little humor, but you know, it's so wonderful that you don't have to just call 911. You call us. The nurse comes out. And then either way, we would tell you what all your options are. Okay? And
yeah, that family made that determination, not us. We just told them the details. So these are just some of the things the nurses can do in the home. We can draw blood. So if you're having levels done for any of your medication, we can do IV therapy if you need it. We can do Foley catheters if you are not urinating. We can do pretty much, the nose life ray is the biggest thing. We take care of ports, PICC lines, we do all that.
colostomy too.
Yep.
But you know, I'll share a little story.
Yep. Question.
Oh, I was just gonna ask, do you use pork?
Yep. Ports, PICC lines, any kind of infusion.
Why do you do everything?
She asked if we can do in ports, if we access ports, we do. PICC lines, we do. IVs, we do. Draw bloods, we do. Draw bloods. Draw bloods.
I mean, would you still need to go to?
Depends what you, well, it depends. If you're on that for arthritis, yeah. And you're on drugs for COPD, you can still go get your treatments.
You know, something that I found helpful, it was a year ago, March 5th. My own stepfather came to hospice. Had been doing this for about a year, had not a clue really what my staff did. You know, because I'm the educator, I'm always out talking with people. I hadn't experienced it. It wasn't until my own stepfather needed it, and we did one of the, you know, a consultation, so he understood what was going on. You know, just so that he was in extreme pain. He had lung cancer, latter stages, and was on hospice for about 5 days. Not typically a good story, longer, you know, good stay, longer is better. But what I thought was so great, he had a CHF episode, didn't know he had CHF, and declined rapidly. We called hospice, and the nurse came out and said, this is nothing that's pertaining to his cancer. If you would like, you can take your father to the hospital, get that looked at, and then come back and we'll resume services. I looked at my nurse like she had 3 heads. And I said, no! But you know what? That's when I realized how valuable. Because if hospice wasn't in my life, then what would I have done? Take him to the hospital, and he was in no shape. Okay? So it was then, I mean, that was my epiphany. You know, I was put here to do this, you know, to spread the word. So, anyway, that's my speech. Hospice is good. Okay, here's the big slide. Exactly. What can hospice do for me with COPD and pulmonary care? Take it away.
You have another slide?
No, that's it.
So pretty much everything I've talked about, all of your therapies that you're on right now, all of your treatments that you're on right now, you do have to qualify. If it's a lung disease, you have to qualify. And in order to qualify, you know, even I forget sometimes what the qualifications are, so I wrote them down. You need to have disabling dyspnea at rest. And I think all of us have that all the time. Disabling dyspnea, meaning this is without oxygen, cannot walk across a room without becoming severely short of breath. Poor response to your bronchodilators or any kind of respiratory treatments. If they're working for you now, great. You know, just keep going. It's awesome. But if you have a patient who, if they are no longer working and they're probably maxed out on their dosing, then you might want to look at what else is going on. Your disease is progressing. Your doctor is constantly seeing you in his office. You're constantly going to the hospital. You're constantly having lung infections, and they're just not getting any better without any reason. You know, there's got to be without any reason. Sometimes it's just a simple infection, and you just need an antibiotic, not hospice. You know, it's not anything like that. And then, of course, the weight loss and your pulse ox, I'm sure you're all familiar with that word, has to be 88% or less on room air.
Taking notes. I always learn something. Okay, so common fears with hospice. Fear of pain and suffering. Many people fear that they will be in excruciating pain and suffering. What do we do for that?
Well, it depends on what the problem is.
One more?
Yeah. No, we don't give morphine right away. I think this gentleman has probably 90% of what everyone thinks about hospice. Oh, they're just going to come out, they're going to give you morphine and just leave you alone to die. That's not true. That may have been true 20 years ago because that's all they knew. But there's so many more treatments available now that morphine's a good drug, don't get me wrong. It works. When you're in exasperation mode and you can't breathe, that morphine gets in there and just relaxes and brings in that air. You know, sometimes you need morphine, but we don't want to use it all the time. You know, we're not, hospice doesn't just say morphine. There's other treatments. So it's per patient.
Fear of the unknown, okay? What I like to draw an analogy to is just like childbirth. You know, it's an incredible experience, changes in your body. It's pretty scientific. So is, you know, when we're declining, okay? It's a very spiritual time, and there's a lot that we can do, and getting support is crucial. And that's what hospice offers, the support. Fear of loss of control. Okay, we want to have control over the situation, but you know that's what the social worker is for, our bereavement person, our nurses. We offer that support.
I like to tell our patients, when we come into your home, when you sign up for hospice, you are still in charge of your care. You tell me what you want, and I'll make it happen. Or we will make it happen. We're not going to tell you, you're not doing this med anymore, you're changing this, and you're going to go here. No, you tell me what you want, and I will get it done.
Fear of what will happen to our loved ones, okay, when you're no longer around. We have hospice bereavement for up to 13 months afterwards. So that's important.
Does anyone know why we would follow the patient's family for 13 months? Any idea why 13, not just 12? It's kind of simple. We follow you. Exactly. We follow every holiday from that person's death, every holiday, and then their actual anniversary of their death. And then we don't just kick you off and say, okay, you're better now, see ya. We will continue to follow them, just not as often. Unless they needed it.
Okay, facts. In the March issue of Health Affairs, found that patients receiving hospice care resulted in fewer hospitalizations, ICU stays, lower rates of admission after 30 days. Yet, only 40% of, 40% of the people in the United States receive hospice. 82% of the people that are on hospice are white as of 2011. I just thought that's an interesting fact. And the typical length of stay, I don't know.
I know, that's a good question. The black culture, as you probably know, they like to take care of their own. They don't like people coming into their home. They don't want to, am I right? They just don't know either. They just don't know what's out there. They just keep going to the doctor, they just keep going along, just keep getting their meds, just keep seeing the physician, just keep going to the emergency